Thank you very much, Dr. Ibanez. It's time to move on, and I'm going to ask Dr. Dan Atar from Oslo, Norway, to present the second study, the beta-mid-Dan-block trial, randomized discontinuation of beta blockers after myocardial infarction.
Thank you, chairpersons. Ladies and gentlemen, dear colleagues, it's a great pleasure to present on behalf of my co-chairpersons, Professor Eva Prescott and Professor John Monkhaugen, the beta-mid-Dan-block trial, a randomized discontinuation of beta blockers after myocardial infarction. This investigator-initiated trial was supported only by public funding and by independent non-public and non-for-profit foundations. Let us turn the wheel of time back 50 years when the Norwegian trialist Dr. Terje Pedersen started enrolling patients into his timolol in secondary prevention after MI study, which was then published in the year 1981. He showed an overwhelming 39% total mortality reduction after 3 years in favor of beta blockers. Since then, as we all know, times have changed for post-MI care, comprising more sensitive diagnostication of AMI, revascularization of PCI, which at that old time wasn't implemented yet, and modern secondary prevention. Yet, many physicians have asked themselves, should beta blockers still be given routinely to post-MI patients without heart failure? We therefore embarked on the beta-mid-Dan-block trial, which was a randomized, open-label, blinded endpoint evaluation superiority trial, with the number of sites depicted here in neighboring Norway and Denmark, respectively. Originally, the two studies were started separately, but then were combined as the study protocols were almost identical. Inclusion criteria for the study was a myocardial infarction within the last 14 days, a mildly reduced or preserved LVEF above 40%, and on the part of beta-mi, a required coronary revascularization. Exclusion criteria were indications or contraindications to beta blockers, including heart failure as an obvious indication. The primary endpoint was all-cause mortality, or MACE, consisting of recurrent MI, unplanned coronary revasc, heart failure, ischemic stroke, or malignant ventricular arrhythmias. Secondary endpoints were each component of the primary endpoint, as well as hospitalization for pacemaker implantation and second or third degree AV block. Statistics. This was a pre-specified analysis performed in the intention to treat population. The power calculation was based on the assumption that beta blockers should prove superiority over no beta blockers. We estimated that approximately 950 primary endpoint events would provide the trial with an 80% power to detect the treatment effect with a hazard ratio of 0.83. Let's turn to the results. This is the study disposition. As you see, patients were randomized to either beta blocker therapy or no beta blocker therapy. There were very few exclusions, basically few that did not meet inclusion criteria on both arms, and a few who did withdraw their consent. Now, importantly, as you see, follow-up was based on nationwide registries. However, adjudication of primary endpoint of events was carried out by blinded event committee. Here are the baseline characteristics of the patients. The median age was 63 years, 22% were women, approximately the same recruitment figures from Denmark and Norway, respectively. And we encounter a classical configuration of risk factors, but notably the number of comorbidities is slightly lower than in contemporary post-MI populations. for example, comorbid AFib only in 2% of the patients. Further, the trial population had STEMI in 48%, approximately 15% had a LVEF between 40 and 49%, 92% have received a PCI, and the medication at discharge encompassed all modern post-infarction therapies as shown below. The median follow-up was 3.5 years. The adherence at 6 months was 89% in the no beta blocker group, and interestingly, also 89% in the beta blocker group. Most of the patients were prescribed metoprolol depot, was used in 95%, and the median dose was 50 milligrams. Let us turn to the primary endpoint result. All-cause mortality, or MACE, was lower in the beta blocker treated patients with a hazard ratio of 0.85 and a level of significance at 0.03. If we look at these secondary endpoints, you see on the upper line the absolute numbers of the primary endpoint with the hazard ratio. And as you go through the secondary endpoint hazard ratio, you see that all of them point in the same direction as the primary endpoint, except the one that is ischemic stroke. Noteworthy is the differential in the occurrence of reinfarctions, shown here, as well as heart failure, both in favor of beta blocker therapy. This forest plot shows the subgroup analysis of beta-amide block trial. You see that all point estimates point on the side of the primary endpoint, namely beta blockers being better than no beta blocker treatment, and this is irrespective of stratification into sex, age, recruiting country, type of myocardial infarction, that is STEMI versus non-STEMI, and LVEF classification. Also interestingly, if we stratified to distinguish lower or above 50 milligrams of beta blocker dose equivalent, there was no difference in the outcome either. In conclusion, this randomized trial of beta blocker therapy versus no beta blocker therapy was carried out in 5,574 patients with an MI and preserved or mildly reduced LVEF. Long-term beta blocker therapy initiated within 14 days post-infarction reduced the primary endpoint of death from any cause or major adverse cardiovascular events. In this adequately powered study, beta blockers proved superior to no beta blockers and may support, thus, their continued role in secondary prevention after myocardial infarction. We would like to thank the various committees who contributed to the evaluation of the study, and of course, we would like to thank all the sites, study personnel, primary investigators across both countries. And last but not least, thanks to the patients who participated. This study is now simultaneously published in the New England Journal of Medicine, and I would like to thank you for your attention.
Thank you, Professor Atar, for this very nice presentation. We move on